Hello students. Today we will be talking about allergies and related emergencies. So first we need to take a look at the immune system because an allergy is a dysfunction of the immune system. So the immune system is a network of cells and tissues and organs that work together to defend the body against attacks by foreign invaders. These foreign invaders are primarily microbes or germs. They're tiny infection-causing organisms such as bacteria, viruses, parasites, and fungi. Because the human body, because we're very warm and we're wet and juicy, this provides an ideal environment for many microbes, so they're always trying to break in so they can grow. It is our immune system's job to find them, first to keep them out, and if they fail at keeping them out, they seek them out and destroy them. So the immune system is divided into two separate types of immunity. There's innate immunity, and that is immunity that you are born with. And then adaptive immunity, which an organism or a human being acquires following a disease exposure. Innate immunity, which is also known as genetic or natural immunity, is immunity that one is born with. This type of immunity is written into your genes, and it offers lifelong protection. The innate immunity response is fast-acting, and it's non-specific, meaning it doesn't respond differently based on the specific virus or bacteria that it detects. The innate immune system encompasses physical barriers and chemical and cellular barriers. Physical barriers protect our body from invasion. It protects us from having the germs getting in, and that includes things like our skin and our eyelashes. Chemical barriers are defense mechanisms that can destroy harmful agents, and these include things like tears and mucus and stomach acid. And then cellular defenses of the innate immune response are non-specific. So these cellular defenses identify pathogens and substances that are potentially dangerous and take steps to neutralize or destroy them. And these are our macrophages. Macrophages are, they eat. Phage means to eat, and they're giant things that come in, cells in our immune system that respond to foreign invaders by coming and eating them up, neutralizing them. Macrophages kind of go across the spectrum of our immunity, but one type is considered innate. You are born with it, and they eat up all the bad germs. So adaptive immunity is an organism's acquired immunity to a specific pathogen. It is not immediate, nor does it always last through an organism's entire lifespan, although it can. The adaptive immune response is marked by T and B lymphocytes, and lymphocytes are our white blood cells. And B lymphocytes release many antibody copies and helps to neutralize or destroy antigens. Antigens are the foreign invaders. We'll talk a little bit more about that in a moment. So here is a picture describing the different types of things the body possesses that help keep us safe or immune to specific disease processes. And we could see here we talked about the innate immunity, about the physical barriers like our skin, and chemical barriers like our stomach acid, and our cellular defenses like our macrophages. And here is adaptive immunity. And within the adaptive immunity response or altered response is where allergies develop. But for our adaptive immunity, we have active immunity, which means you have natural immunity. You've had the disease, something such as chickenpox, let's say. So I had chickenpox when I was younger before a vaccine was available. So then I become immune to it because I've had that disease, even if I'm exposed to it again. And so a lot of you probably had the chickenpox vaccine because it wasn't created in time for me. So you have the vaccine, and that's called active immunity. You also have something called passive immunity, and that an example of that is from mother to baby through the placenta or also through the breast milk. Additionally, we have artificial passive immunity. You may remember at the beginning of the COVID-19 pandemic, they were asking people that had had the COVID-19 virus to come and donate their blood so that they could get the antibodies out of their blood and give it to people that were high risk of bad outcomes from COVID. And that's a form of artificial passive immunity. So in a healthy immune system, the body has the ability to distinguish between the body's own cells, called self, and foreign cells, non-self. When the immune defenders encounter cells or organisms carrying markers that say foreign, they quickly launch an attack. So anything that can generate, and you see here, GEN, generate an immune response is called an antigen. And here we have GEN again. So an antigen can be a microbe, such as a virus, or even part of a microbe. It can also be tissue or cells from another person, except an identical twin, which carry non-self markers and act as antigens. And this explains why tissue and organ transplants may be rejected. In abnormal situations, the immune system can mistake self for non-self and launch an attack against its own body's cells and tissues. And the result of this is autoimmune disease. Some forms of arthritis, diabetes are autoimmune disease. In other cases, the immune system responds to a seemingly harmless foreign substance, such as ragweed pollen, and the result is allergy. And we call this kind of antigen an allergen. So in the normal immune response, lymphocytes, white blood cells, are created by our body to fight foreign invaders, the non-self. These lymphocytes begin as immature stem cells in the bone marrow, and they grow into specific immune cell types, such as T cells, B cells, or phagocytes. So humoral immunity is an antibody-mediated response that occurs when foreign materials, the antigens, are detected in the body. This foreign material typically includes extracellular invaders such as bacteria. This mechanism is primarily driven by B lymphocytes. So humoral immunity is the B cell lymphocytes. Our B cells are white blood cells. It's a type of immune cell that produces antibodies. So B produces antibodies, and there is a B in antibodies. So our body produces antibodies, and specifically the B lymphocytes. So it produces these antibodies after it detects a specific antigen. Once antibodies effectively bind to their target antigen, they can either neutralize their target antigen directly, or they can induce the recruitment of other immune cells, such as T cells, phagocytes, that promote the antigen's removal or destruction. So the first time the body encounters a novel disease agent, its response is known as the primary immune response. When the B lymphocytes or B cells encounter a new type of antigen, they create antibodies specific to the antigen designed to destroy or neutralize it. Simultaneously, the B cells create memory cells, which are a type of B cell that survives for decades and can detect the pathogen during subsequent exposure. It takes the body time to create antigen-specific antibodies the first time, and therefore this response takes longer than subsequent or secondary, tertiary responses. If an organism encounters the same pathogen a second time, the immune system's response will be faster and more robust than the primary immune response. So this is great at things like chickenpox, preventing us from getting the chickenpox for a second time. However, this same sequence of events happens when you encounter an allergen. That the B cells create these antibodies that have memory, and these memory cells remember. And we'll talk about the allergic response in a few more slides and how it can be dangerous. So another name for antibodies is immunoglobulins. And so here are the specific immunoglobulins that we know so far, antibodies that are created by our B cells. We have IgA, which is very, very abundant, and it's concentrated in our body's fluids, such as our saliva, our tears, and the secretions of our respiratory tract. IgD, whose function is poorly understood at this time. However, it remains attached to B cells, and they think it may play a key role in initiating an early B cell response. IgE is associated with immediate allergic reactions. Its natural job is to protect us against parasitic infections. However, it's also the villain responsible for the symptoms of allergy and anaphylaxis. IgG crosses the placenta. It also coats microbes, speeding their uptake by other cells in the immune system. And then IgM is the first one produced in the chain in the response. When the body, the B cells, respond to the allergen or antigen, it's the first one produced, and it's very effective at killing bacteria. And here is just a little pictogram showing you how all the different immunoglobulins are shaped differently and how they are created, different types are created related to the foreign invader. And here is showing a B lymphocyte with its antibodies. And antibodies usually, not always, but a lot of them sort of have a Y shape. And you can see it attaches to bacteria, neutralizing them, or it can also attach to an antigen. And an antigen here, this antigen might be ragweed, and it's attaching to the antigen, and it can precipitate or create an allergic reaction within the body. Now, another type of immunity is cellular or cell-mediated immunity. And unlike humoral immunity, it doesn't have to depend on antibodies for its immune response. Cell-mediated immunity is primarily driven by mature T cells, macrophages, and also the release of cytokines in response to an antigen. Cellular immunity is involved in local inflammatory reactions. It's also involved in delayed allergic reactions, which is a type 4. So a delayed allergic reaction, so this, you might think of it as like, so I'm allergic to adhesives and tapes. So when I had some false eyelashes put on, the glue that they used to attach them, within 2 days, my eyes were almost completely swollen shut. And that is considered a delayed cellular immunity type 4 response. Those kind of things that we get when we wear like inexpensive jewelry, tape on the skin, some dental adhesives and things can cause this type of response in the oral cavity. A deficiency or a low amount of T cells is the hallmark or an indication of HIV infection. And here we see the cell-mediated immune response. So something has entered this macrophage, and then these antigen MHC complexes form on the outside of the cell. And these form, they're called antigen presenting cells, and these help to create helper T cells and also memory T cells. The helper T cells will release the cytokines, and this is like a chemical signal to the memory T cells to start to divide and actually become killer T cells. And these killer T cells will then kill the infected cell if something has got into the cell, like a virus, a bacteria, and then the cell dies. So they don't use, so cell-mediated, it works on its own. It does not create antibodies. These T cells actually do the neutralizing or the killing of the bacteria or the infected cells themselves. And they're also looking at T cells to use them to fight cancer, to look for those cells that have become cancerous. So the allergic response or the reaction uses the immune response against a non-infectious substance like ragweed or tape, but it uses the defense system inappropriately. So the goals of the immune response is to recognize the enemy, react, and then remember it for future encounters. So that would be great for chickenpox, not so great for something like bee stings or penicillin allergy. So the first time the allergy-prone person runs across an allergen such as ragweed, they'll make a large amount of ragweed IgE antibody or immunoglobulin. And this IgE actually attaches itself to mast cells. These little Ys, these antibodies, attach themselves to mast cells. The second time the person has a brush with ragweed, that IgE primed mast cell will release its powerful chemicals. These are chemicals of inflammation, things like histamine and leukotrienes and bradykinin and prostaglandins. So these all get spilled out, and then the person will suffer the wheezing, sneezing, runny nose, watery eyes, and itching of allergy. So allergy is a state of abnormal. It's not normal to be sensitive, to have the immune system respond this way. So we call it a state of abnormal hypersensitivity. The allergen is the substance that generates the allergic response. It may enter the body through many routes. So the allergen, you can inhale it, it can be injected, you can swallow it. Lots of different ways to become or have the allergen enter the body. And some common allergens include penicillin, bee stings, wasp stings, sulfa drugs, also sulfites, plants, and chemicals. So the importance with the medical history is a history of any allergy makes it much more likely a patient will have an allergic reaction to substances used in dentistry and to any substance actually. My husband has anaphylactic reaction to wasp stings. This makes it much more likely that he'll be allergic to something else as he proceeds through the lifespan. So what do we need to know as clinicians? What they're allergic to. Because some drugs have something called cross-allergenicity. And that means if you had an allergic reaction to penicillin, you'll be allergic to all of the cillins. Ampicillin, amoxicillin, doxycycline, cloxacillin, all of the cillins you'll be allergic to. Additionally, some drugs, if you're allergic to penicillin, you may also be allergic to cefalexin. The cephalosporins are very chemically related structurally to penicillins. So people that are related or allergic to penicillin, 10% of the time, they're also allergic to cephalosporins. And the other thing we need to know, is it a true allergic reaction? So you must need to know the signs and symptoms of allergic reaction. A lot of times a patient may tell you, well, I had Novocaine at my last visit and I got a little woozy, or I felt like I was going to faint, and my heart was beating really fast, so I'm allergic to it. That is not a true allergic reaction absent other factors like skin reactions, edema, redness, itching, hives. That sometimes is a normal psychogenic reaction. If someone faints after an injection, or if their heart is beating fast, that's actually a normal response to the epinephrine within the local anesthesia cartridge. So you really need to have good questions and figure out, was this really an allergy what they had? Other questions, what medications do they take? Do they take Benadryl when they have an allergic reaction? Do they tell you they have 3 EpiPens in their purse? How do they react during the reaction? What are the signs and symptoms? Airway, tongue swelling, lip swelling. Those are important things to know. Does it happen right away, or does it happen 3-4 days down the road? History of prior exposure to highly allergic substances. Things like bee venom, wasp venom, right? They've been stung by a bee before. What happened? History of a prior allergic reaction in the dental setting. One more consideration, are they atopic? So atopic is a genetic disposition or a tendency due to hereditary reasons to develop allergic reactions. The person produces elevated levels of IgE upon exposure to environmental antigens, and especially ones that are inhaled or ingested. So some people are considered atopic. They tend to develop immediate allergic reactions. These people are more likely to die from anaphylaxis. So my husband he is atopic. History of allergies. If he inhales, if someone is cutting poison ivy down the street or mowing it, he will break out if he inhales poison ivy. Same with my children. They are atopic. They're stung by something, swelling, eyes shutting. So they have a hereditary tendency to produce larger than normal amounts of IgE. My husband has had one episode of anaphylaxis which was life-threatening. So people that are atopic with this family history are more likely to die from anaphylaxis due to their tendency to create larger than normal amounts of IgE, that antibody, that immunoglobulin created by our B cells. So here are some dialogue questions that you may ask. Excuse me. What are you allergic to? What happens? Describe that reaction. How long before you develop the symptoms? What do you usually do about it? Like, do they do nothing? Do they just take a Benadryl, they're all set? Have you had any reactions in the dental setting? And have you ever been hospitalized due to an allergic reaction? So here are the different types of allergic reactions that can happen. So we have a type 1. So in dentistry and in life, we will most likely be dealing with the type 1, the immediate reaction, and the type 4, delayed. The type 1, that is B cell driven, the humoral, IgE. Additionally, strong hereditary factors. It's the most life-threatening, and your reaction time is significant. Type 2 is cytotoxic, and these type of allergies have to do with blood incompatibilities. You were given the wrong type, the blood type, during a transfusion. Also associated with autoimmune disorders. Type 3 is an immune complex disease. It's also known as serum sickness. It's driven by IgG. Again, B cell, humoral immunity. And then type 4 is the delayed. It's cell mediated. It doesn't have to do with antibodies. The T cells do the dirty work themselves. And this is a delayed reaction. Another thing that we can see in dentistry, this type 4 reaction, is something called contact dermatitis. So it usually happens after repeated exposures of direct contact. A lot of clinicians developed contact dermatitis to latex gloves. It can also be seen in the oral mucosa from dental materials. So what do you see? Redness. The skin becomes red due to vasodilation. Edema. Tissue swells. Vesicles. Vesicles are small, fluid-filled, clear fluid-filled little, I don't want to use vesicles again, patches. I have a picture of them that form on the skin. And then pruritus. Pruritus is the medical term for itching. So with contact dermatitis, you can take something orally, but usually you might want to rub a topical antihistamine or a topical steroid, something like cortisone 10, hydrocortisone cream. Topical steroids really decrease the inflammation. The antihistamine will help with the itching. So this is what it can look like on someone's hand. This redness and a little bit of swelling. I don't see any vesicles here. Those clear fluid-filled pustules that form on the skin, but this looks like it would be pretty itchy. Let's talk about another medical term, urticaria. Those are hives. Hives are like larger. The vesicles, tiny, tiny. Hives are getting larger, fluid-filled patches on the skin. It's often accompanied by pruritus, which is itching. So it's a vascular reaction. The vessels are reaction. The vessels are reacting. So you get erythema, which is redness, and edema, which is swelling. So what can happen is the blood vessels dilate, sending more white blood cells to the area that's having the reaction. So blood vessels dilate, so you see the redness. Additionally, you get edema because during that allergic reaction, as those cells are trying to fight what they think is an antigen, but it's just an allergen, the vessels themselves become more permeable, which means fluid and blood starts leaking out of our vessels. And instead of staying in the circulatory system, now they're in the tissue spaces, and you'll get edema in your hands. So this can be very mild, but it can also be very severe. You can have hives everywhere, and they can start coalescing, meaning they actually start joining together and becoming giant. They could be localized to maybe just your trunk, or they could be from the top of your head to the tip of your toes. So if someone breaks out in hives after being exposed to a certain allergen, bee venom, penicillin. That is considered a type 1 IgE-driven reaction. The treatment for hives would be an oral, you swallow it, antihistamine like Benadryl. So let's look here. So this is some hives. Now it doesn't look red, so depending, right, on if the person has pale skin, if they have dark skin. So someone with pale skin, this would look very red. Someone with darker skin, it may take on a more pink hue. But here we can see, like this I might consider like a vesicle, and this larger one is becoming a hive, and they actually start growing together or coalescing, and they'll get bigger and bigger. They'll start joining. Like this flat part here will go away, and they'll get bigger and bigger. So sometimes they get really, really big. And at that point, people might think it's urticaria, but it's something called angioneurotic edema, or angioedema for short. So this is localized, and it includes, so if you think about hives, it's on the surface, it's at the top layer. But angioedema goes deep, deep, deep into the deep dermis or subcutaneous tissues. So think of urticaria as superficial and angioedema is deep. So it's usually a huge single lesion. It doesn't have defined or raised borders. The other thing that makes it different than hives, it's not itchy and it's not painful. It is an allergic reaction. However, this is what makes it dangerous and a little different. Sometimes that swelling, that edema, it can happen anywhere. It can happen in your genitals, which is actually a common site. It can happen in your feet, in your hands. But what if it happens in your neck? If it happens there and it involves the larynx, it can actually compromise the airway. The patient will tell you it feels like their throat is closing. All right, so sometimes this angioedema is delayed. If it's delayed, it doesn't happen right away, then upon exposure to the antigen or allergen, it usually isn't as dangerous. However, if it happens immediately following like a penicillin administration, that can indicate that a more serious reaction will follow. So you can see here the person's eye is closing, they have swelling through here. So over time, the eyes can swell completely shut. So we're starting to talk about the head here is where this angioedema is happening. We're getting worried. Can this be, can it spread to the throat? Can it compromise the airway? Because if it's in your hands, feet, or genitals, that's quite a distance away from the throat. We're not as worried. So how do we treat it if someone is having this reaction? Supine, we want to maintain the airway. Administer O2. So this is a little different than we're used to, because usually if airway is involved, we want to keep them up. But for this particular one, we want them to be down as we're administering, figuring out their blood pressure. This one, with angioedema, there's a high risk of becoming unconscious. So we're going to try to keep them down and keep them comfortable by administering O2 and monitoring their vitals, giving them an antihistamine such as Benadryl. This is if the airway is not involved. Now, if the airway is involved, again, we want to try to maintain an airway, administer oxygen. We're getting ready here to have to do CPR. We want to administer an EpiPen. So we want to get them down so we can treat them as needed. Much easier to perform if they become unconscious, we want them to be flat. Monitor their vital signs. If you note that their blood pressure is falling, that indicates that the angioedema is becoming an anaphylactic reaction, which is a respiratory and circulatory system complete collapse. So what is anaphylaxis? A severe and acutely life-threatening type 1 allergic reaction. It can cause death in minutes. If something is delivered by injection, that is the route most likely to result in anaphylaxis in an allergic person. Additionally, so if you've injected penicillin into someone, you can't get it out, right? It's in their bloodstream. If I was allergic to penicillin and I took a penicillin tablet by accident, I could make you throw it up to get it out of the bloodstream. So injection route is the most dangerous way to give a drug that can result in anaphylaxis in an allergic person, because there's no way to get it out. So in anaphylaxis, respiratory, our breathing, and circulatory, our bloodstream, occur together and early in the reaction. So we talked a little bit about what happens with the B lymphocytes when you're exposed to an antigen like chicken pox, and all about the memory cells. The same thing happens in the allergen or allergic response. So for a true allergic reaction to happen, the patient must have a primary exposure or a first exposure to the antigen, and that is called the sensitizing dose. So for my husband, for example, he's been stung before by a wasp. So he had that initial exposure to the antigen, the wasp venom. And his body, his B lymphocytes, created immunoglobulins or antibodies specific to that antigen. In a susceptible person, usually that atopic person, the person with a history of allergic reactions, high levels of the immunoglobulin IgE are formed. These IgEs, those little Y antibodies, attach themselves to the cell membranes of the mast cells and also are basophils. So in that atopic person, again, there is a genetic tendency to overreact to an allergen because of their tendency to produce this overabundance of IgE. So after the sensitizing dose, he was stung by a wasp years and years ago. There is something called the latent period, and that's like the sleepy period. And that could be days to months, which the IgE antibodies, the body continues to produce them, and the patient is then considered sensitized to that specific antigen. So then what happens is he disrupts a wasp nest and he gets stung by 3 wasps. Now that is the challenge or the allergic dose, a subsequent or second exposure to the antigen that results in the antigen antibody reaction. This reaction causes the release of the chemical mediators of inflammation from our mast cells. The mast cells, they degranulate. The IgE that's attached to them from the first exposure causes them to have this fast response. The mast cells degranulate and spit out all of these chemical mediators of inflammation. These include histamine and leukotrienes. Leukotrienes have another name. They're also called SRSA, the slow reacting substance of anaphylaxis. And these are responsible for causing the physical changes that we can see in anaphylaxis. So what do we see? So we see the histamine causes vasodilation, increased capillary permeability. So the vasodilation, the person gets red. The increased capillary permeability, the blood and fluid leak out of our capillaries. We get swollen. Constriction of smooth muscle. We have diarrhea and vomiting. The smooth muscle we're talking about here is the GI tube that runs from our mouth to our butt. Stimulation of secretions. Just like in asthma, all that mucus, everything is heading into our lungs. And then skin reactions, itching, urticaria, pain. Sometimes it can be painful when those hives are formed. And then the slow reacting, the SRSA, also known as leukotrienes, cause bronchoconstriction. Now we can't breathe. All of our blood is flowing out of our capillaries, so our circulatory system is in danger, and now we can't breathe due to the bronchoconstriction. So signs, symptoms, skin reactions, hives, urticaria, itching. Additionally, that angioneurotic edema that goes deep, deep, deep. It's not on the surface like the hives. This is deep, deep swelling that can involve the throat, closing off that airway. The GI, the patient may tell you they feel sick. They may have cramps, nausea, vomiting, diarrhea. So at this point, the body is trying to get rid of this allergen in any way possible, and it's saying to everything, evacuate, right? So you're going to be throwing up, also potentially at the same time having diarrhea. Respiratory, you might feel a feeling of tightness in the chest, a weight on the chest, coughing, wheezing. They may, depending on their skin tone, become cyanotic. The bronchioles go into spasm. When they go into spasm, that bronchoconstriction, right? The airways are closing down. And then additionally, we have laryngeal edema, which can result in a total airway obstruction. And it's the most common cause of death and anaphylaxis. The cardiovascular system, so they may have palpitations, also tachycardia. The heart's going to start beating really fast, but additionally the blood pressure is going down. So you might be like, well, how is the blood pressure going down? It's going down because we've talked before. How do you get high blood pressure? Too much fluid, or your pipes are too small. What's happening is your pipes are getting actually bigger. Your blood vessels are opening, and the fluid, instead of staying in them, are spilling out into your tissue spaces. Blood pressure goes down, which makes the heart start beating very fast, right? Trying to get the blood back up to it because we need the blood to get to the brain. The tachycardia, right, can make the sequence, the coordinated contraction of the heart get out of sequence. Now you have an arrhythmia. That arrhythmia starts going, and you can have a complete cardiovascular cardiac arrest. The patient may also be sweating. They may have anxiety, and they may be restless. Now, in some cases, the signs and symptoms will proceed in this order. In other cases, the reaction is so severe that the signs and symptoms occur all at once. All of this happens at one time, and the patient will lose consciousness quickly. This is very, very difficult to treat and most often fatal. The most common causes of anaphylactic reaction, death, are penicillin, bee stings, and wasp stings. And patients with the atopic history are much more likely to die from an anaphylactic reaction than patients with no history of allergy. So what are we going to do? Someone is having anaphylaxis, blood pressure's dropping, hives, red, airways closing. You've got to activate EMS, and you've got to get them there fast. All right. You need to administer an EpiPen, most likely multiple EpiPens, because epinephrine is a very short duration and the anaphylaxis can start building again. You want to try to maintain that airway, give them some oxygen, administer antihistamines and steroids if you have them, and they need to be transported to the hospital. So that drug of choice, that DOC, epinephrine, and the EpiPen, super rapid onset. All of a sudden the person's looking better, but it's also really, really short. And because it's really, really short, you may need to give them another EpiPen administration. Any medical kit should include a minimum of 2 EpiPens because the duration of action of epinephrine is so short and the anaphylactic reaction can start building again. Epinephrine is considered an antagonist. It fights against the allergen or what's happening in the body. It produces actions, the exact opposite of those caused by the histamines and the leukotrienes or the SRS. Wait a minute. Slow reacting substances of SA of anaphylaxis. Epinephrine, what does it do? Oops. It vasoconstricts. Yay. Can raise that blood pressure, which we want. It bronchodilates. It opens the airway so the person can breathe. And it also will stimulate the heart if the person has gone into cardiac arrest. So additional meds is steroids. Corticosteroids decrease inflammation. They also help epinephrine in terms of minimizing all of the actions produced by the histamines and leukotrienes. That is something usually for the hospital to give. Additionally, antihistamines such as Benadryl can block further action of the circulating histamine because they fight against the histamine, they're antihistamines, and prevents reoccurrence of the reaction. Okay, that's it for today.